Hello students, today we are talking about hyperandrogenism. Hyperandrogenism is a state of increased serum androgen level with or without any biological effect of hyperandrogenemia. Androgens are necessary for normal ovarian and sexual function. They play an important role in cognition, bone health, muscle mass, body composition, mood, energy. The obstetrician gynecologist must have a strong knowledge base regarding the role of androgens in normal female physiology. Androgens are produced by the adrenal glands, the ovary, and from peripheral conversion. Hyperandrogenism depends on violation of androgen synthesis, violation of transport, and violation of action on peripheral organs. In clinical practice, they would describe a few forms of hyperandrogenism: true hyperandrogenism and the other forms of hyperandrogenism. The true hyperandrogenism may be adrenal in case of adrenal hyperplasia or adrenal tumor, and ovary hyperandrogenism, which is the cure in case of polycystic ovarian syndrome and releasing ovarian tumors. Major causes of hyperandrogenism is polycystic ovarian syndrome, adrenal hyperplasia, tumors of the ovary and adrenal glands, and Cushing syndrome. Adults have two types of hair, vellus and terminal. Vellus hair is non-pigmented and soft and covers the entire body. Terminal hair is on the other hand pigmented and thick. They cover scalp, axilla, and pubic area. During puberty, androgens are responsible for the conversion of the vellus to terminal hair, resulting to the development of pubic and axillary hair. An abnormal increase in terminal hair is due to androgens excess or increased 5-alpha reductase activity. This enzyme converts testosterone to the more potent dihydrotestosterone. Dihydrotestosterone is believed to be the main stimulant of the terminal hair development. On this image, you may see both vellus and terminal hair. Androgenic hormones in the female can stimulate abnormal terminal hair growth, voice and muscle changes, hair loss, clitoral enlargement, and reduction in breast size. Hirsutism refers to the increase in terminal hair on the face, chest, back, lower abdomen, and inner thighs in a woman. Where hirsutism describes a pattern of masculine hair growth, viralization refers to the development of male features such as deepening of the voice, frontal balding, increased muscle mass, clitoromegaly, breast atrophy, and male body habitus. The evaluation of hirsutism and virilism in the female patient is complex and requires the understanding of pituitary, adrenal, and ovarian function with detailed attention to the pathway of glucocorticoid, mineralocorticoid, androgen, and estrogen synthesis. Congenital adrenal hyperplasia refers to a constellation of enzyme deficiency involved in steroidogenesis. Is caused by enzyme deficiency that result in precursors excess, thus resulting in androgen excess. The most common disorder is 21-alpha hydroxylase deficiency. Patients with congenital adrenal hyperplasia do not synthesize cortisol or mineralocorticoids. Congenital adrenal hyperplasia affects approximately 2% of the population and is caused by the alteration in the genes for 21-hydroxylase, which are carried on chromosome 6. The genetic defect is autosomal recessive and has variable penetrance. As I already told you, the most common disorder is 21-alpha hydroxylase deficiency. An enzymatic block at this step will lead to the accumulation of 70-alpha hydroxyprogesterone, which is then shunted to the androgen pathways. The other type of congenital adrenal hyperplasia that can be associated with viralization include 11-beta-hydroxylase and also 3-beta-hydroxysteroid dehydrogenase deficiency. Patients with 11-beta-hydroxylase deficiency present with similar symptoms of androgen excess. Because of accumulate precursor are shunted to the androstenedione and testosterone productions pathway. That's why when we discuss the cause of adrenal hyperplasia, we discuss two enzymatic deficiency. It's 21-hydroxylase deficiency. 21-hydroxylase catalyzes the conversion of progesterone and 70-alpha hydroxyprogesterone to the desoxycorticosterone, and 11-beta hydroxylase deficiency. This enzyme catalyzes the conversion of desoxycorticosterone to cortisol. In clinical practice, depend on the level of 21-hydroxylase deficiency and the level of hyperandrogenism, we distinguish three forms: severe, mild, and manifested at puberty. Congenital adrenal hyperplasia or classical adrenal hyperplasia present with abnormally enlarged adrenal glands that produce excessive amounts of androgens, leading to abnormal sexual development in females affected with this disease. Newborn most likely have ambiguous or atypical external genitalia with masculinization or viralization signs. Also, they are genetically female and will have normal internal reproductive organs. Now you can see different symptoms of classical adrenal hyperplasia. Infant girls with classical adrenal hyperplasia typically have a larger clitoris. Children with classical adrenal hyperplasia often go through the puberty earlier than normal. There is abnormal absent periods, deep voice, early puberty, facial hair, poor weight gain. But more of that, about 75% of people with classical congenital adrenal hyperplasia due to 21-hydroxylase deficiency also have a deficiency of the hormone aldosterone, leading to the inability to retain salt and water. This results in excessive loss of water, dehydration, and low circulating blood volume, hypovolemia, and also abnormal low blood pressure, it's hypertension. The Prader scale, or Prader staging, named after Dr. Andrea Prader, is coarse rating system for the measurement of the degree of viralization of the genitalia of the human body. It primarily relates to virilization of the female genitalia in case of congenital adrenal hyperplasia and identifies 5 distinct stages. But in recent time has been used to describe the range of differentiation of genitalia, with normal infant presentation being shown on either end of the scale, female on the left and male on the right. Now, stage 0 would be considered as having normal female external genitalia. Stage 1 has a mildly large clitoris and slightly reduced vaginal opening size. This degree may go unnoticed or may be simply assumed to be within normal variation. Stage 2. Genitalia are obviously abnormal to the eye, with the phallus intermediate in size and a small vaginal opening with a separate urethral opening. Stage 3 shows a further enlarged phallus with a single urogenital sinus and almost complete fusion of the labia. Stage 4 looks more male than female, with an empty scrotum and a phallus the size of a normal penis, but not quite free enough to the perineum. The single small ureterovaginal opening at the base or on the shaft of the phallus would be considered of hypospadias in a male. This common opening can predispose to urinary obstruction and infection. Stage 5 denotes complete male virilization with a normally formed penis with a urethral opening at or near the tip. The scrotum is normally formed but empty. The internal pelvic organs include normal ovaries and uterus, and the vagina connects internally with the urethra. Those infants are not visibly ambiguous, are usually assumed to be ordinary boys with undescended testes. In most cases, the diagnosis of congenital adrenal hyperplasia is not suspected until signs of salt wasting develop a week later. And the last stage is the stage 6, indicate normal male presentation with no hypospadism present and normal testes. On this image you see external genitalia of a girl with congenital adrenal hyperplasia. Treatment of classical congenital adrenal hyperplasia starts soon after birth and is needed throughout the patient's life. Newborn with classical congenital adrenal hyperplasia should have a team of healthcare providers, including specialists in pediatry, endocrinology, urogynecology, surgery, physiology, and genetics. Usually, surgery is thought to be easier when performed at about 6 to 12 months after birth. A surgery called feminizing genitoplasty in order to change the look and function of their genitals. Next form is manifested at puberty adrenal hyperplasia. When 21-hydroxylase deficiency is manifested at puberty, adrenarche may precede telarche. The history of pubic hair growth occurring before the onset of breast development may be a clinical clue to this disorder. The diagnosis of 21-hydroxylase deficiency is made by measuring increased 7-deoxyprogesterone in plasma during the follicular phase. And clinically, we have also mild adrenal hyperplasia, which is frequently associated with terminal body hair acne, subtle alteration in menstrual cycle, and infertility. Patients can also have sonographic evidence of polycystic appearing ovaries. The diagnosis of 21-hydroxylase deficiency is made by measuring increased 70-hydroxyprogesterone in plasma during the follicular phase. Patients with classic 21-hydroxylase deficiency will have significantly elevated plasma 70-hydroxyprogesterone levels, usually over 2000 nanogram per deciliter. Patients with less severe 21-hydroxylase deficiency may have mildly elevated basal levels, 200 nanograms per deciliter, and an increase to usually 1000 nanogram per deciliter in response to adrenocorticotropic hormone stimulation. Dehydroepiandrosterone sulfate and androstenedione will also be elevated and contribute to the hirsutism and viralizing signs. As we discussed before, less common cause of adrenal hyperplasia is 11-beta-hydroxylase deficiency. The enzyme 11-beta-hydroxylase catalyzes the conversion of desoxycorticosterone to cortisol. A deficiency in this enzyme also results in increased androgen production. The clinical features of 11-beta-hydroxylase deficiency are mild hypertension and mild hirsutism. The diagnosis of 11-beta-hydroxylase deficiency is made by demonstrating increased plasma desoxycorticosterone. Treatment of adrenal hyperplasia is aimed at restoring normal cortisol levels. Treatment reduces circulating androgen levels. Adrenal hyperplasia may be treated by the administration of glucocorticoid agents to restore ovulation. Glucocorticoid administration is therefore appropriate therapy for infertility or hirsutism in individuals with late-onset adrenal hyperplasia. In patients with 21-hydroxylase deficiency, prednisone before bedtime is used to suppress endogenous adrenocorticotropic hormone. Alternatively, anti-androgens may be used successfully to treat hirsutism, alone or in combination with dexamethasone. And now, let's talk about ovarian hyperandrogenism. Polycystic ovarian syndrome, PCOS, is a common endocrinopathy typified by oligoovulation or anovulation, signs of androgen excess, and multiple small ovarian cysts. Polycystic ovary syndrome is the most common cause of androgen excess and hirsutism. These endocrine metabolic disorders affecting reproductive age women with a prevalence of up to 12%. To establish the polycystic ovarian syndrome diagnosis, the patient should have two of the following criteria: oligoovulation or anovulation, usually marked by irregular menstrual cycle, biochemical or clinical evidence of hyperandrogenism, polycystic appearing ovaries on ultrasound. It is also important to rule out other endocrine disorders that can mimic polycystic ovarian syndrome, such as congenital adrenal hyperplasia, Cushing syndrome, and hyperprolactinemia. The cause of androgen excess appears to be related to altered and excess LH stimulation, leading to cystic changes in the ovaries and increased ovarian androgen secretion. Polycystic ovarian syndrome patients have higher serum LH concentration when compared to match control and exhibit overexpression of LH receptors in theca and granulosa cells. Hypersecretion of androgens by the stromal theca cells of the polycystic ovary leads not only to the cardinal clinical manifestation of the syndrome, hyperandrogenism, but it also one of the mechanisms whereby follicle growth is inhibited with the resultant excess of immature follicles. Hypersecretion of LH by the pituitary, a result both of disordered ovarian pituitary feedback and exaggerated pulses of gonadotropin-releasing hormone from the hypothalamus, stimulates testosterone secretion by the ovary. Furthermore, insulin is a potent stimulus for androgen secretion by the ovary, which by way of a different receptor for insulin does not exhibit insulin resistance. Insulin therefore amplifies the effect of LH and additionally magnifies the degree of hyperandrogenism by suppressing liver production of the main carrier protein sex hormone binding globulin, thus elevating the free androgen index. It is a combination of genetic abnormalities combined with environmental factors such as nutrition, body weight, which then affect expression of the syndrome. The typical woman with polycystic ovarian syndrome has many of the signs of metabolic syndrome. Approximately 40% of patients with polycystic ovarian syndrome have impaired glucose tolerance, and 8% have over type 2 diabetes mellitus. Those patients should be screened for diabetes. Women who are obese and also many slim women with polycystic ovarian syndrome will have insulin resistance and elevated serum concentration of insulin. Insulin resistance is defined as reduced glucose response to a given amount of insulin. The bioavailability of testosterone is affected by the serum concentration of steroid hormone binding globulin. High levels of insulin lowers the production of steroid hormone binding globulin and so increase the free fraction of androgen. Elevated serum androgen concentration stimulate peripheral androgen receptors, resulting in an increase in 5-alpha reductase activity, directly increasing the conversion of testosterone to the more potent metabolite dehydrotestosterone. Obesity, acanthosis nigricans, and hirsutism occur frequently in polycystic ovarian syndrome and are future known to be associated with insulin resistance. There have been a large number of studies demonstrating the presence of insulin resistance and corresponding hyperinsulinemia in both obese and non-obese women with polycystic ovarian syndrome. Obese women with polycystic ovarian syndrome have consistently been shown to be more insulin resistant than weight-matched controls. It appears that obesity and polycystic ovarian syndrome have an additive effect on the degree and severity of insulin resistance and subsequent hyperinsulinemia in the group of women. The insulin resistance causes compensatory hypersecretion of insulin, particularly in response to glucose. Insulin resistance is restricted to the extra action of insulin on glucose dispersal. Women with polycystic ovarian syndrome who are oligomenorrhea are more likely to be insulin resistant than those with regular cycles. Acanthosis nigricans is a skin disorder characterized by hyperpigmentation and hyperkeratosis of the skin, occurring mainly in the folds of the skin. The cause of acanthosis nigricans is still not clearly defined, but it appears to be related to insulin resistance. In many women with polycystic ovarian syndrome, obesity seems to be the common factor. Women with polycystic ovarian syndrome have a greater truncal abdominal fat distribution, as demonstrated by a higher waist-hip ratio. The central distribution of fat is independent of body mass index and associated with higher plasma insulin and triglyceride concentration and reduced high-density cholesterol concentration. There is evidence that insulin resistance, central obesity, and hyperandrogenemia have an adverse effect on lipid metabolism. A rising serum concentration of testosterone was associated with an increased risk of hirsutism, infertility, and cycle disturbance. The rates of infertility and menstrual cycle disturbance also increase with increasing serum LH concentration. Irregular menses, hirsutism, acne, androgenic alopecia, infertility, obesity, metabolic disturbance, abnormal lipid levels, and glucose intolerance are short-term consequences of polycystic ovarian syndrome, where diabetes mellitus, cardiovascular disease, and endometrial cancer are long-term consequences. Endometrial adenocarcinoma is the second most common female genital malignancy. Hypertension and type 2 diabetes mellitus have long been linked to endometrial cancer, conditions that are now known also to be associated with polycystic ovarian syndrome. The true risk of endometrial carcinoma in women with clearly defined polycystic ovarian syndrome, however, is difficult to ascertain. Approximately 80% of patients with polycystic ovarian syndrome has menstrual dysfunction. Anovulation occurs in 90% cases. Infertility diagnosed in approximately 98% cases. Hirsutism in 60%, and more than in half cases of polycystic ovarian syndrome have obesity. Hirsutism in a female is defined as the presence of dark terminal hairs distributed in a male pattern. Androgenic hormones in the female can stimulate abnormal terminal hair growth. On this image, you see typically patient with polycystic ovarian syndrome who has terminal hair growth on the face. On this slide, you see Ferriman-Gallwey score. The Ferriman-Gallwey score is a method of evaluating and quantifying hirsutism in women. The method was originally published in 1961 by Ferriman and Gallwey in the Journal of Clinical Endocrinology. The original method used 11 body areas to assess hair growth, but was decreased to 9 body areas in the modified method. That is those areas: upper lip, chin, chest, upper back, lower back, upper abdomen, lower abdomen, upper arms, forearms, thighs, and legs. In the modified method, hair growth is rated from 0 to 4 in each of the 9 locations, where 0 means no growth of terminal hair, and 4 extensive hair growth. Those separate scores are summed to provide a total hormonal hirsutism score. A patient's score may therefore range from a minimum score of 0 to a maximum score of 36. Score less than 8, consider it as normal. Score between 8 and 15, consider it mild hirsutism. And score more than 15, it's severe hirsutism. That table shows polycystic ovarian syndrome diagnostic criteria in different years. You see criteria and number of criteria required for diagnosis. The polycystic ovarian syndrome is diagnosed in the presence of 2 out the following 3 criteria: oligoanovulation, hyperandrogenism, sonographic signs for polycystic ovaries. This is description of the morphology of the polycystic ovary. The morphology of the polycystic ovary has been redefined as an ovary with 12 or more follicles measuring from 2 to 9 mm in diameter and or increased ovarian volume. If there is a follicle greater than 10 mm in diameter, the scan should be repeated. The presence of single polycystic ovary is sufficient to provide the diagnosis. The distribution of the follicles and the description of the stroma are not required in the diagnosis. Increased stromal echogenicity and stromal volume are specific to polycystic ovary, but it has been shown that the measurement of the ovarian volume is a good surrogate for the quantification of the stroma in clinical practice. A woman having polycystic ovary in the absence of an ovulation disorder or hyperandrogenism should not be considering as having polycystic ovarian syndrome. Also, she may develop symptoms over time, for example, if she gains weight. Identification of polycystic ovaries by ultrasound doesn't automatically confer of a diagnosis of polycystic ovarian syndrome. Polycystic ovaries are commonly detected by ultrasound. The ultrasound criteria for diagnosis of polycystic ovaries are increased in the number of follicles and the amount of stroma as compared with normal ovaries, resulting in an increase in ovarian volume. The cysts are not the cysts in the sense that they do contain oocytes, and indeed are follicles whose development has been arrested. On this image, you see ultrasound scan of polycystic ovary. Transvaginal sonography displays multiple small hypoechoic cysts and increased ovarian volume. Hormonal studies in women with polycystic ovarian syndrome shows the following: increased LH to FSH ratio, increased LH level in 65% cases, increased free testosterone in 91% cases, increased in prolactin level in 31%, and decreased steroid hormone binding globulins practically in 98% cases. On this table, you see differential diagnosis between causes of oligo or anovulation. The causes may be polycystic ovarian syndrome, hyperthyroidism, hypothyroidism, hyperprolactinemia, hypogonadotropic hypogonadism, and premature ovarian failure. Treatment of the patient with hirsutism, hyperandrogenism, or hyperandrogenic chronic anovulation depends upon the underlying etiology and the desire for pregnancy. Hirsutism is slow to respond to hormone suppression. Result may not be seen for up to 6 months. Unfortunately, androgen suppression will not alter previous hair growth patterns. Mechanical methods of hair removal should also be considered. Lifestyle modification should be first line in the management of hyperandrogenism. For those individuals who suffer from hirsutism and obesity, weight loss of even 5% of original body weight can often improve symptoms related to polycystic ovarian syndrome. Weight loss may result in an elevation of steroid hormone binding globulin, a decrease in bioavailable testosterone, an improvement in insulin sensitivity. Oral contraceptives reduce circulating gonadotropin levels and increase steroid hormone binding globulin level. Both work to decrease circulating androgens. That's why oral contraceptives are the first line of treatment of oligomenorrhea caused by polycystic ovarian syndrome. Several androgen-secreting ovarian tumors can cause hirsutism and viralization, including Sertoli Leydig cell tumors. Sertoli Leydig cell tumors, also called androblastoma, are ovarian neoplasm that secrete testosterone. Those tumors constitute less than 0.4% of ovarian tumors and usually occur in women between the ages of 20 and 40. The tumor is most often unilateral and may reach a size of 7 to 10 centimeters in diameter. The history and physical examination give critical clue in diagnosing subjects who present with hirsutism and testosterone-secreting ovarian tumors. Testosterone-secreting tumors usually have a more rapid onset and most have a hirsutism and viralizing signs. Women with Sertoli Leydig cell tumor have a rapid onset of acne, hirsutism, amenorrhea, and viralization. A characteristic clinical course of two overlapping stages is described. First, the stage of defeminization, characterized by amenorrhea, breast atrophy, and loss of the subcutaneous fatty deposits responsible for the rounding of the feminine figure. And second, the stage of masculinization, characterized by clitoral hypertrophy, hirsutism, and deepening of the voice. Those changes may occur over 6 months or less. For diagnosis, we need history, physical examination, pelvic examination, and laboratory studies. Laboratory studies of this disorder show suppression of FSH and LH, low plasma androstenedione, and marked elevation of testosterone. An ovarian mass may be palpable on pelvic examination. Once the diagnosis is suspected, there should be no delay in surgical removal of the involved ovary. The contralateral ovary should be inspected, and if it is found to be enlarged, it should be bisected for gross inspection. Following surgical removal of a Sertoli Leydig cell tumor, ovulatory cycles return spontaneously and further progression of hirsutism is arrested. If the clitoris has become enlarged, it doesn't revert to its pre-treatment size. However, temporal hair is restored and the body habitus becomes feminine once again. Terminal hair in a sexual distribution will not revert to villous hair, but the growth and pigmentation will slow. Most patients will require mechanical removal of excess hair following removal of the ovarian tumor. The 10-year survival rates for this low-grade malignant ovarian tumor approximate 90 to 95%. Now we are talking about uncommon viralizing ovarian tumors, and we start with gynandroblastoma. Ovarian gynandroblastoma is an extremely rare sex cord stomal tumor showing morphological evidence of both female granulosa cell tumor and male Sertoli Leydig cell tumor components. Almost all ovarian gynandroblastoma cases have been reported in children, adolescents, or women of reproductive age. Robert Mayer was the first to describe this type of tumor in 1930. The predominant clinical feature is masculinization. Also, estrogen production may simultaneously produce endometrial hyperplasia and irregular uterine bleeding. Another uncommon viralizing ovarian tumor is a lipid cell tumor. Lipid cell tumors are usually small ovarian tumors containing sheets of round, clear, pale staining cells with a differential histologic diagnosis of hilar cell tumor, stromal luteoma of pregnancy, and Sertoli-Leydig cell tumors. The clinical presentation is masculinization or defeminization associated with elevated 70 ketosteroids in many cases. And another uncommon viralizing ovarian tumor is an hilar cell tumor. Hilar cell tumors arise from an overgrowth of major hilar cells or from ovarian mesenchyme and are typically found in postmenopausal women. They are characterized clinically by masculinization, which support the idea that hilar cells are the homologs of the interstitial or Leydig cells of the testes. Histologically, the tumors contain pathognomonic ring albuminoid crystals in most cases, and grossly they are always small, unilateral, and benign. Treatment is surgical removal for those three rare tumors. Cushing syndrome is an adrenal disease resulting in adrenal excess. Cushing syndrome is characterized by excess production of cortisol. Because the intermediates in production are androgens, they will be concomitant hyperandrogenic state. Cushing syndrome may be caused by pituitary adenoma, ectopic sources of adrenocorticotropic hormone, and tumors of the adrenal gland. The most common cause of Cushing syndrome is Cushing disease, which refers to a pituitary adenoma that hypersecretes adrenocorticotropic hormone. Paraneoplastic syndromes, such as non-pituitary adrenocorticotropic hormone secreting tumors, may also lead to increased adrenocorticotropic hormone levels. Adrenal gland tumors usually result in decreased levels of adrenocorticotropic hormone secondary to the negative feedback from the increased levels of adrenal steroid hormones. All three of those situations lead to the glucocorticoid excess characteristic of Cushing syndrome, as well as hirsutism, acne, and menstrual irregularities related to adrenal androgen production. As a result of an adrenal neoplasm or an adrenocorticotropic hormone-producing tumor, the patient demonstrates signs of corticosteroid excess that include truncal obesity, moon-like face, glucose intolerance, skin thinning with stria, osteoporosis, proximal muscle weakness in addition to evidence of hyperandrogenism, and menstrual irregularities. On this image, you see the person with Cushing syndrome and the common signs of Cushing syndrome, which is growth of the fat on the neck, moon face, hirsutism, and stria on the abdomen and on the arms. Stria appear because the patient with Cushing syndrome has weight gain and the skin is too stretched in it, which is then thin and weakened, causing it to hemorrhage. Stria may be purple or red. as you can see on this image. The Cushing syndrome diagnosis is based on medical history, physical exam, measurement of adrenocorticotropic hormone, which is decreased in Cushing syndrome, and cortisol, which is increased, MRI of the pituitary gland. When Cushing syndrome is suspected, it can be diagnosed with one of the following first-line tests. It's a late-night salivary cortisol or the overnight dexamethasone suppression test. In patients with a high index of suspicion, it is recommended to do 2 of the above first-line tests. Idiopathic hirsutism. Hirsutism is considered idiopathic in the absence of adrenal or ovarian pathology, an exogenous source of androgens, or use some drugs, which is also may lead hirsutism. Patients may actually have acute androgen production, but many will have normal circulating androgen levels. There may be an increase in peripheral androgen production owing to elevated 5-alpha reductase activity at the level of the skin and hair follicles. A detailed history including time of onset, progression, and symptoms of viralization or hirsutism should be obtained, as well as pubertal, menstrual, and reproductive history. Because various medication can affect androgen level by affecting steroid hormones binding globulins or intrinsic androgenic activity, a detailed drug history should be obtained. A family history is also important in order to look for genetic disorder such as congenital adrenal hyperplasia. Laboratory evaluation should include free testosterone, 70-oxyprogesterone, and dehydroepiandrosterone sulfate measurement. An elevation in free testosterone confirms androgen excess, and a concomitant elevation in dehydroepiandrosterone suggests an adrenal source. An elevated 70-oxyprogesterone is suggestive to congenital adrenal hyperplasia. If an adrenal source is suspected, an abdominal CT should be performed to rule out an adrenal tumor, as well as further tests to diagnose Cushing syndrome or congenital adrenal hyperplasia. If the dehydroepiandrosterone sulfate is normal or minimally elevated, an ovarian source should be considered, and a pelvic ultrasound or CT should be performed to rule out an ovarian neoplasm. An elevation in the LH and FSH ratio greater than 3 is suggestive to polycystic ovarian syndrome. However, most obstetrician gynecologists do not diagnose polycystic ovarian syndrome with LH and FSH ratio any longer. Rapid onset of viralization and testosterone levels more than 200 nanograms per deciliter may indicate an ovarian neoplasm. At times, the source of androgen excess is not readily evident, and further diagnostic tests such as abdominal MRI and selective venous sampling need to be done for localization. In the hirsute woman with normal free testosterone, an assay for 5-alpha reductase activity is performed to determine whether increased peripheral enzymatic activity is responsible for the development of hirsutism. Thank you for your attention.